Okay, morning ladies and gentlemen. Thanks for spending your time with us on a Saturday morning. We try to make this a very relaxed session. So you see the speaker, even we usually go to conferences, people wear tie, we don't. Tie is very, very constricting. Trauma surgeons don't wear tie one. Okay, so let me start off by sharing this thing. The day I read something, okay, it's supposed to be a joke, but to me it's actually not really a joke, but it get me thinking, and that's why I come up with this topic. Okay, the thing I read was that there was during this orientation in one of the school of engineering, okay, this dean put out a pen and showed it to all the new students in the school, okay, say that they spend millions and millions of dollars, they invented this pen that can write in space where there's no gravity, okay. They spend millions and millions of dollars because no gravity, nothing. How does the ink from the roller pen come out? Then the student put up their hand and said, "Sir, why don't you just use a pencil instead? Would that solve your problem? Why did you spend a million of dollars?" So that gets me thinking. Okay, we may have a lot of new toys, a lot of things that we can introduce you, okay, to help you manage the patient better. But if we don't get our basic correct, okay, you don't deal with your airway, your breathing, your circulation properly, okay, with all these new toys, it's still not going to save a patient, okay. And in this thing, why we involve the nurses in all these things? Because nurses are usually the first person, okay, nurses, the paramedics, the medics are the first person to be on scene to deal with all these acute events before the doctors arrive, okay. Hence, the theme of this year's Trauma Symposium will be called Back to Basic. Okay, we're back to dealing with the A, B, C, D, E. Okay, even though not exactly as A, B, C, D, E. Okay, so without further ado, let me introduce the first speaker. Okay, the first speaker, of course, will be dealing with airway. Okay, Dr. Rahul Goswami is here. He's a consultant from our emergency department. Our ED is a very contained unit, okay? For the nurses who have not gone down to ED, you probably wouldn't have known him. Okay, maybe you heard him shouting from the ED that far away, okay? But the purpose of this, but today he'll talk to you about all the airway. He's a very interesting character. Okay, he will have a lot of interesting story to tell you. The reason why is that because he actually has a lot of experience in trauma management. He worked in many places, okay? Worked across 3 continents to learn about trauma and to share his knowledge of trauma, of airway management with you. Okay, let's go ahead together for Dr. Rahul.
Okay, morning everyone. I'm just going to walk around here, it'll be easier to understand what's going on. I'm going to use the mannequin as well. So, welcome everyone. Thank you, Chi Kyong. Before I start, just let me be the first to say the hospital and institution is going to miss him when he's gone, and they will only realize his value when he's not around, as usual. So we're going to talk about the basics of airway management and a little bit about breathing. So breathing is pretty simple, there's not much to it in trauma. Generally, if you have a breathing problem, putting a chest drain in, that's generally about it in trauma. So we're going to talk a lot more about airways and things. That's a critical skill when it comes to it. So I have been exposed to a lot of this primarily because I used to work in places which are not tertiary institutions. I have worked in tertiary institutions and high-flyer units, but we're talking about places which you are not that familiar with sometimes. And I used to do, before I came here, aeromedical retrieval. I still do a little bit of it. And this is a place which is in the middle of nowhere, literally in the middle of nowhere. And sometimes when you're stuck in the middle of nowhere, you tend to realize what the important things really are. Because you don't have, in my case where I was for a period of time, there was no bloods, no x-rays, no surgeon, no anesthetist, maybe an anesthetist who's a GP who's half an hour away, no real support or ICU, and after hours, no other investigations apart from a blood gas machine. So when you have a child or a pregnant lady coming to you, or both at the same time, when you have none of these things, you tend to find God very quickly. And after that, you tend to wonder why did you listen very well in school, and what's wrong with you. But after a while, you look at what the good things are being done. You look at what the very good doctors and the very good nurses do. My first night as a registrar in a small hospital, a district hospital, it's the senior nurses who saved me time and time again from doing silly stuff. And what they do is very basic, but they do it very, very well. And this is synonymous with the theme that goes on today. You have to learn the basics very, very well. And what I show most of my medical students and nurses and postgrads and even junior consultants is this slide, which an intensivist gave to me a while back. And it says, life is pretty simple. Air goes in and out, blood goes round and round, anything else or any variation is bad. So air goes in and out, blood goes round and round in trauma, anything else is bad. And once you work around this concept and you build upon the layers which we're going to demonstrate today, you'll understand that trauma management, though very complex sometimes, boils down to the very basics of this. So sometimes, or in many occasions where you don't see, you might have to actually protect the airway of someone who's come in after being hit by a bus, a truck, or fallen down and they're unconscious. Maybe they're combative, you need to scan them, maybe there's all sorts of reasons where they're unconscious and you need to protect their airway. So that's what we're trying to do in the end. But doing that has many, many hazards. Because what you are saying is that, okay man, look, I know you've been hit by a bus and your blood pressure is low, but what I'm going to do to you now is stop you breathing, destroy your blood pressure, and then maybe put a piece of tube down your throat. That's what you're trying to do. And to do that, you are actually challenging all of this. Because you are reducing their blood pressure, which is already reduced, and you are stopping them from moving air in and out. So you have to be really, really sure that what you're doing is supporting their vital functions before you start giving them silly drugs. So what exactly is intubation? Well, this is what it looks like. And not to steal the thunder from my anesthetist colleagues, but putting the tube in is what you're going to see. That's the vocal cords. Sometimes you see it, sometimes you don't. Sometimes there's blood, sometimes there isn't. Sometimes you can't see anything at all. Sometimes you can see a wonderful view like this. Sometimes you can actually pass the tube, sometimes you can't. Sometimes you need adjuncts, like a bougie. Sometimes you don't. And sometimes even though it's in, it's not really in. And then you have to do it again. But take it from me, and take it from even my anesthetist colleagues here, that passing the tube is the easy part. Keeping people alive while you're doing all of that, that's the hard part. And I know those of you who work in the theatre and seen these things, and seen in ED most of the time, you know that. Passing the tube is easy. All the other stuff, that's hard. So if you want to know all the other stuff, you have to have sort of a system in place for that. And that's the important part that we're trying to introduce. Because this is the type of patients that we see in the emergency department. So we don't see what you saw earlier. That's easy. You've got anesthetists nearby, it's faster, things are stable. But ED patients are far from that. You know that. ED patients are unfasted, they're sick, they're shocked, they're underperfused, they're uncompromised in their lung function, you're under time pressure to move things along, and sometimes they just crash right in front of you. So there's many, many, many things which you are unprepared for in emergency patients. But that's why we do emergency sometimes. That's why we like it. We like patients like that. So we get to do things. And we get to move things along. That's why we get paid, fortunately or unfortunately. So if you've got somebody who's already hemorrhaging, let's just say it's this person over here. They've got what looks like a difficult airway. There's a hematoma somewhere near the neck on the left side there. I'm sorry, this doesn't look very well, but if you look at the neck, there's a big bruise, and this guy was unconscious, and before that he had stridor, and he couldn't breathe very well, and we had to put him down. But putting him down because he's got a low blood pressure, he can't breathe very well, he's not perfusing his brain or his lungs very well, that's a problem. So you have to prepare for what you're going to do. And preparing for a difficult airway like this is not something that everybody does very well. Because anticipation is something that comes with a little bit of experience. And you have to see it to believe it. So if there's one maxim that you want to know, it's this. Is that failure to intubate the patient is not a problem. Failure to oxygenate the patient, that's the major problem. This was a sign hanging on one of my last few EDs where I worked, and it was crucial because there's no anesthetists nearby. It was to remind people that just because you can't tube, and take it from me, I'm an average intubator. I'm very average. Why? Because I'm an occasional intubator. Because I've got plenty of trainees for the last few years that want to do everything. So I only get to do stuff when there's a problem, and that's like, putting you the odds against you. So I'm very average. But I don't let my patients desat. And I don't let my patients go hypotensive when I'm doing it. That's the key. The key is to keep them alive while somebody is doing silly things with their airway and giving them silly drugs. Yeah? So there are a few things that you need to keep in check before you do stuff. And what we've done is come up with some sort of a guide for you, which we can print out and hand over to you. I'm sure you have it in your handouts. As to what to do in every situation, not just trauma, in every situation, so that you have a system in place to handle stuff when it goes wrong. And that's what we need. So, what do I have here? It's a typical trauma patient. Let's just imagine it was the one that you saw. He's bleeding away from somewhere else, and maybe his legs were cut off, which happened in the past. He's got a collar on, he's got a few things on right now. So these are the basics that you require. First things first, to dispel a few myths. Do they really need a collar? People who are unconscious, we assume they've got some sort of injury. But do they really need a collar? And do they really need to be lying flat on the table? The answer is no. Because there are plenty of things that you can impair you from doing what you have to do when the collar is on. So when they are under control, meaning they're either unconscious or they're coherent enough to understand, oi, keep still, that's enough. Have somebody at the end of your bed hold on and provide what we call cervical stabilization. So basically what you don't want this person to do is to while you're manipulating, trying to put the air in. It's to prevent the intubator from doing stupid things like this. Okay? Because you want to keep your neck still. So this thing about the necks, even people who sell pillows know about them. Okay? That's your normal position. You sleep like that, and sometimes you even stand like that. If you put yourself against a wall, that's how you will look. Because nobody, apart from one population, sleeps like that, with their head straight down. Because that is your normal anatomical position. So when we put people in collars and don't bother to do this, even though it's trauma, we are causing problems. Because this is an abnormal position with a collar on. Okay? There's only one population which sleeps like that. Anybody know? Anyone? Yes? Anyone? Children. So only children have large enough heads, generally infants and toddlers, which don't require you to put either a pillow or a donut or something else underneath to maintain normal stabilization. Okay? So this has been shown off in studies, in various studies. And yes, of course, there's the 1 in a million case where if you shake it slightly, it's an old person, you might damage the thing. But you have to imagine what's more important at this time. And at this time, whatever you're doing, you have to maintain an airway first. I know cervical spines are important. Okay? But take this. This is absolutely normal. So don't worry about taking it off. So long as you don't allow somebody to do that. So, you need suction, because there's lots of blood. And sometimes when there's too much blood, you need 2 suction catheters. Sometimes you need 3 suction catheters. You just get somebody to hold it while you do the important things. Yeah? So there are times where things are flooded and you can't see anything, but suction will take it away. You just need more than 1. Okay? And working suction, check before. Underneath the shoulder, that's what's important. Because you don't want to start finding stuff and groping for stuff when you're actually seeing problems arise there. You don't want to let go, because the view is all important, as you saw. Oxygenation is done via nasal prongs as well as a bag and mask or a Laerdale. Now you may wonder, this guy is not too bright because he's got 2 pieces of oxygenation going on. What's the point of having nasal prongs when he's already doing that? Does anybody know why we do that? Does anybody know? I've set this to 10 liters, and I do this for every case, and we have it in our department that we do this for every case. Why do we have nasal prongs running at 10 liters and then do something like this? Anyone? Anybody seen it before? This is called apneic oxygenation. So, what happens is, back, if you are conscious or not breathing. Once we're ready to tube, remove this aside. There's no oxygenation going on. But if you have this blowing at 10 liters, you're filling up the dead space and you're sort of oxygenating the patient as best you can while there's no bagging going on. So while the patient is not really breathing, you are pushing oxygen, pure oxygen, down and oxygenating as much as you can. Does it really help a lot? No. Does it harm? No, it doesn't. So we do it. So these are little tips and tricks that you can pick up every now and then, which is important. You want to do it on the wall? Do it on the wall. And this is called apneic oxygenation. The next thing that we need to really wonder is that when all of these things are going on, you can't manage it on your own. You can't manage it with one person. In our department, we need to have at least 2 nurses when we're doing critical intubations or inductions like this. Because there is no way that you are going to manage something when the only other nurse there is going to pass you critical airway equipment. So that doesn't happen. Who's going to give the drugs? Who's going to do laryngeal manipulation? Who's going to go get another set of drugs if we need it? Who's going to get rescue devices if we need that? This thing has saved more doctors and patients than any intubation. Because this thing is easy, and the paramedics and nurses know this. Anybody can put this down. So this needs to be at the side as well when you're starting an intubation. Yeah. So you can see that personnel are very, very important. And nothing happens without. Who's going to go and run and get somebody else if you can't do it? Who's going to call in this case if you really can't do it? Who's going to get the video laryngoscopy unit that's not there? So you must have personnel next to you. If you do not fulfill this requirement, everything else down the line is going to go bad. Maybe not 10 out of 10 times, but 7 to 8 out of 10 times things are going to go bad if you don't have any personnel next to you. Preferably, you want them in their designated roles as they are. There's no point having 3 consultants doing what nurses do best. No point. I can tell you, it's a disaster. Okay? And there's really no point giving the most junior person the most difficult task. So if you are having somebody who has never seen an intubation done in a shocked patient who is about to crash normally, giving your trainee nurse or trainee resident the intubating or the airway nurse job is also a disaster waiting to happen. So you must be really cognizant of the fact that the most senior people in the department or the unit at that time know that intubation is going on. Yeah? Because what you are doing, remember, is stopping this person from breathing and reducing their sympathetic drive and destroying their inherent catecholamine resistance. Yeah? So what you're saying is that, okay, I know that you're bleeding, but I'm going to give you another drug which drops your blood pressure, and I'm going to breathe for you. Trust me, I'm a doctor. Okay? That's what you're trying to do. So it's very, very crucial. I don't want to cut into the talks about hemorrhagic shock and how you treat them, but it's very important to deal with the aspects when we're trying to give them drugs. And drugs are what we do somewhat badly as well. Some of you, and this is for the doctors among you, might think that shock patients require drugs which don't drop the blood pressure, and you're going to choose etomidate, thinking that it doesn't do anything like that. But let's dispel a few more myths over here. Okay? There is no drug which doesn't drop your blood pressure. Maybe some drugs are better than that, but there is no drug, because there's a whole lot of things going on. When we sedate you, we are telling your body to calm down in every way. That means your intrinsic, adrenaline, NORAD, everything goes down as well. Okay? So there's lots of things that we're doing to you. So Richard Dutton, if you've heard of him, is one of the world's premier trauma anesthetists. And he said, in shock trauma patients, it doesn't matter what you give. And he's been doing this since before I was born. Right? It doesn't matter what you give. It's the dose. You can give anything you want, so long as you taper the dose. You can give Thiopental, is what he used to give for years. And that drug is the old school drug. It plummets your blood pressure. But he gave 1/10 of the dose. Okay? So what I give, I'm not saying that you should try Thiopental in your next resuscitation, but you need to know what you're giving. You need to know the drugs that you're giving. What I give in shocked patients with lousy blood pressure, and I'm about to make them worse, is what most people around the world give nowadays, and that's ketamine. Ketamine's got a bad reputation from the 70s because some group of people came up and said, I don't use it in head injuries, it's bad for head injuries. But that was the 1970s. It's 40 years later, and we should kick that out and move on. Why should we move on? Because the literature and all the evidence points to the fact that we should move on. These are meta-analyses coming from the Germans. And if you know somebody more OCD than a German anesthetist, let me know. It's hardly some. The Australians got into the act a year later, nothing wrong with ketamine. The Americans got into the act saying, look people, there's nothing wrong with ketamine. Until in 2010, the Canadians came about and said, look, this is the mother of all meta-analyses. There's nothing wrong with ketamine in head injury. There is a caveat. If you've got somebody who's got high blood pressure, super high blood pressure because they've got an intrinsic head injury, then you probably don't want to give ketamine, because the idea then is to drop their blood pressure a little bit. So they've even shown that ketamine with midazolam, a little bit of midazolam, is actually neuroprotective. So forget about that myth that ketamine is bad in head injuries. It's gone. The only thing that you want to do is make sure that the blood pressure remains at somewhere in normal levels where you can manage the patient, right? So we're talking about a mean arterial pressure of around 65. In head injuries, you want it to be around 85. If it's too high, I won't give it. I'll pick something else. But they're not in shock if it's too high, generally. Okay? So, now that we know that ketamine's okay, give it whenever you have a shock patient. Yeah? And don't be surprised anymore. The point we're trying to make with all these statements and all these myth dispelling is that it is everybody's job to know the basics. If you're going to get a trauma patient out of trouble, it needs to be a concerted effort. And it doesn't mean that the most junior doctor who sees it first has to figure out everything from the oxygenation all the way down to ketamine. No. It needs to be everybody's job to know that these are the things that are required. The stuff in the list that we've made up, and I drew that up, and it's a big poster in our emergency department because we want people to know the basics. And once you have this checklist approach, and there's no shame in it, everybody forgets things. Everybody. A lot of you in the surgical community, you guys have moved into the checklist sort of sphere way before any of us have. Because you know that is the only way to keep your skills up, and the only way to remind new, old, and middle grade people that this is the ideal way to do things. It's not always right. You don't have to follow whatever we wrote there. You can have your own system of doing things. You can give your own drugs. That's not important. What is important is that you have a system so that people remember, and that when new people come, they remember. You can deal with that. Any problems that come in, so long as you're prepared for it. And that's the key. A little bit about breathing then. This is probably more for the medical portions. Just a couple of slides just to pique your interest. If there's any doctors around, forget trauma people. What's wrong with this X-ray? Anybody can say it, doesn't have to be a doctor if you know what's going on. So the story is fall from height. So there are certain clues there. It's a portable film, and you can see a spinal board. So you know that this patient's somewhere in the emergency department and they had a fall. Does anybody know what's wrong with this X-ray? Another diagnosis, please. If you're a resident, you will be noticed by your faculty. Does anybody know? If not, we'll go to the embarrassing point where we try and see whether these guys know. Okay. That's pressure for you. What's wrong with this X-ray, sir? Please enlighten me.
Usually the resident tell me before I get the Well, by the mediastinum?
Why then mediastinum? Not from a fall from height, but he's good. He's obviously, what he's saying is that the aorta is slightly wide. But that's not the abnormality here. He's right, but that's not the abnormality here. Anybody else? Yes, you're pointing, young sir. Yeah, I saw you pointing, come on, be brave. Just shout it out. It's fine. He got it wrong, it's fine. Something English. What? 2 sticks? No, don't worry about that. Good catch, but no, the 2 sticks are not, that's not the problem. But good catch, okay. Right, so this is subtle, and the reason why it's here is because it is subtle. And yeah, that's just part of the backboard, don't worry. Good catch though. So the 2 sticks are not impaling him, don't worry. Anything generally that's symmetrical is usually non-pathological. Okay? So the thing about this is that this is a pneumothorax. Why is it not a classical pneumothorax? It's because he's lying down. And when you're lying down, you don't pick up input. Yeah, go on. Yeah, we're on time. Fracture. 2 points. So subtle things are subtle. So you've got a fracture on this side, okay? But a fracture doesn't really mean much unless there's a pneumothorax associated. What do we do with fractures? We do nothing. We give pain, okay? And we watch out for flail, which is a clinical diagnosis, yeah? Flail is not an X-ray diagnosis. It is a clinical diagnosis for the doctors out there. So it's a fracture here. But that's where people went wrong. Sorry again. That's where people went wrong. Focus on this side is wrong. This guy has got a pneumothorax here. What's yes? Who said yes? Who said yes? Why does he have a pneumothorax here? Because this is what you call a deep sulcus sign. So there is not supposed to be so much air going down to this portion, and it's called a sulcus, which is something that goes deep in. So a deep sulcus sign is something which shows up as a pneumothorax when nothing else shows up as a pneumothorax. So for this reason, and a lot of other reasons, we generally don't depend in the emergency department. Nowadays, we generally don't depend on chest x-rays as a tool for ruling out pneumothorax. What we use is ultrasound. Yeah? It is much, much better than a chest x-ray. So, unfortunately, the video takes time to load. But what you will see is sliding of the lung pleura, and when there is no pneumothorax, you will see, normally, you will see sliding of the pleura here. You look at the whitest line that you can find. So the whitest line you can find is your pleural interface, and if you can see ants crawling or insects crawling on your white line, there is no pneumothorax. This is far more sensitive than a chest X-ray on supine patients especially. This is a pneumothorax because the white line that you see, forget about shaking, the white line that you see, that's not moving. So for nurses out there, that's what we're looking for when we plant a big gel and lots of gel on somebody's chest. We're not looking for blood, we're looking for pneumothorax. Okay? So this has basically replaced chest X-rays in modern ED diagnostics for pneumothoraces. Last X-ray, just to pique your interest. This is somebody who got hit by a truck. Low speed, so hit by a truck at low speed. Does anybody want to pick up the abnormality? Anyone? There is also a slight deep sulcus sign on that side, but that's not the abnormality. Does anyone pick up the abnormality? Anybody? Anybody? Okay.
Well, it's obvious clavicle fractures, a bit of mediastinal widening, I think, so you got to look for other signs of blunt chest trauma.
So he's got the major ones. Clavicle on that side, and a widened mediastinum again. So widened mediastinum is on a lot of films. Why? Because these are supine films, and you're shooting from the top. So when your angle is dispersed like that, your mediastinum will appear a little bit wide. It doesn't mean there's always a problem. It means you need to investigate further. Okay? But the problem with this is that once again, we got distracted by the big injury on that side. And some of you at the back will realize that the right side of this picture, that means the patient's left, is whiter than the left side of the picture, that means the patient's right. So let me be more clear on this. The patient's left chest looks whiter than the right chest. So what's that? Anyone? Lots of whispering. Hey, what's that? Anyone? Yeah, I'm almost done. 2 minutes more. So if we say that dark is air, white is blood or fluid. You're right. So in this case, in trauma, white is blood. So why don't you see a meniscus or an effusion? Same reason you didn't see the pneumothorax. Patient is supine, which means the blood pools at the bottom like that. And when it pools at the bottom of the lung, you don't see it as a level, you see it as everything white. It doesn't mean the whole lung is covered in blood, it just means the bottom portion is all covered in blood, because that's where the blood goes, because they're lying down. So this one has a hemopneumothorax on that side, but he's got injuries that are obvious on this side. Okay? So things will trip you up sometimes, and that's why we use all sorts of modalities nowadays. So in summary, this is a team sport. You need to be really, really good at your clinical picture, the drugs that you're giving, and the radiology that you do, or the instruments that you use to detect these things. Because all of these things play a part in the quick disposition of where this patient is going. It doesn't matter if you can't intubate, and I can't stress this anymore, because there are other ways of solving the problem. There are countries where this is all they use. This is all the paramedics use. Does every patient who comes in with a paramedic using this aspirate? No, not at all. Okay? So do not be alarmed, even though you are nurses helping out the doctor if they cannot intubate. That's not the problem. It's the lack of oxygenation which is the problem. And we'll leave you with a picture, another picture of my old office where we used to work. And it demonstrates that trauma patients, the storm that's coming is something that you cannot see sometimes because they don't give you the typical signs and they crash pretty quickly. Yeah? So the storm is sometimes hard to detect. But it doesn't mean that it's always going to end badly. There are chances to save them again and again and again. The younger they are, the more chances they give you. And the rainbow is always out there, but you just have to see it. Thank you for attending and listening. I'll take any questions.
Thanks, Olo. See, I tell you, he's a very interesting guy. I thought the basic of life is love. Now you get more life. Okay. Next, let's introduce our next. Okay, maybe just one question for our. Maybe some of you who would like to put ultrasound on the chest. Is there a specific place where you put your probe and things like that?
So. Yeah, so just in case you're seeing something to ultrasound, doesn't matter. So you basically need just two things. You need to make sure that you see both lungs. That's about it. So don't just put it on one and like, oh, that's abnormal. That doesn't work. You need to compare both lungs, and basically you need about 3 levels on each lung. So on each side, make sure you do it about 3 levels. Because just because you don't see pneumothorax here, doesn't mean there's nothing going on over there. So basically, both sides and a couple of levels.
Okay, thanks. Okay, so let me introduce the next speaker. Okay, Dr. Raj Kumar. Okay, he's one of the latest addition to our hospital and Department of Anesthesia and Intensive Care. And trust me, it's a good catch compared to all the experience that we have. Okay, he's an experienced anesthetist. He works in a lot of places in the UK. Okay, and a very established intensivist as well. So I think he's a very good person to talk to you about management of circulation.